Good morning. Welcome to Radically Rural 2021 and welcome to the Healthcare Track. This is session 3 about funding excellent healthcare. And you have some nationally renowned people here who can help you do that. There's Alan Smart with Philanthropic RX. Did I get that right, Alan? No, I did. It's a miracle. Kristen Sandy with the Rural Health Hub. And Terrell Eisinger, who is the Executive Director? CEO, thank you. CEO of the National State Offices of Rural Health. And they have a great presentation for you today. So thanks for coming. And we hope to see everybody again next year. We hope this is our first year of a healthcare track. So yes, next year we'll have fabulous things and significant improvements from what we've learned. So I'm going to hand it over to Alan, right?
Thank you all very much. Great to be here. Greetings from Winston-Salem, North Carolina, although I am in Keene, New Hampshire today. And we also have my friends and colleagues, Christine from North Dakota and Terrell from Michigan, formerly of Nevada, I believe. We're going to get started. And while the track is called Healthcare, much of what we're going to talk about today is actually a much broader spectrum that we'll roughly call social determinants of health. And we'll have a few slides on that. And that's certainly been a change over the years as we've talked about interactions with funders. So I'm going to start a little bit and kind of orient the audience to the kinds of things that particularly private foundations who would consider themselves health funders or in the health space are really thinking about, and specifically to rural. And some of these are more generalizable to urban and rural, but certainly our focus today will be rural. Just as way of background, I was a funder leader in the southern part of the United States, first in Louisiana, North Carolina for about 20 years, but also had a prior life in Catholic healthcare in both rural and urban settings. So I've been at this for quite a while, and the last 3 or 4 years have really concentrated on this whole idea that funders can and should be much more attentive to the needs of rural America, that there is a best practice, a field of rural philanthropy that can inform that, and that not just rural interested funders, but funders of all kinds should be interested in this for some of the reasons we're going to talk about in terms of just the way people relate between rural and urban areas in terms of work and school and just kind of the lessening differentiation often between urban, suburban, and rural as many of the urban cities continue to grow into what were once rural areas. So Philanthropy Works is myself and some colleagues around the country who are ex-funders or researchers who are really interested in kind of the deep learning about these issues. So hopefully we'll bring some of that today to your interest, whether you're a nonprofit, a funder, government person, anything in between. So there we go. So first off, talk a little bit about the changes in the health funding landscape. And I alluded to one of them, which is the top bullet. We have really moved from healthcare to health. If you talk 20 years ago in the interests of private funders, there were a number of funders who were interested in healthcare. And that may have been as simple as funding a dentist in a rural community or a nurse practitioner, or expanding mental health services by having 2 more MSWs for a community-based clinic or something related to adult aging and medication, pharmacy, education perhaps. From the funder perspective, that has really expanded. And this focus is on something called social determinants of health, touch upon in a second. One of the things that I really try to advocate for and promote, and I think is getting some momentum in the funder community, this whole idea that the health of the community is not the responsibility of physicians, the hospitals, the public health system, that communities which really have a future in terms of the vitality and re-envisioning even the economic base, that it really is dependent upon all people in leadership roles and really embracing this idea of a healthy community. That the county manager, the mayor, the school superintendent, the president of the community college really recognizes that having a healthier community really speaks to their interests, but is really part of being a community leader. And no longer can we say, well, people are healthy or unhealthy because the healthcare system is working well, or perhaps not. This is a much deeper entrenched issue in urban communities, but much more so in rural places where people have multiple leadership roles. There's a smaller kind of human resource pool to provide leadership to these kinds of things, and there's just kind of a cross-pollination between these sectors. And the last thing that has really fundamentally shifted what the private foundation landscape looks like, and next slide we'll talk about, in addition, the constellation of private foundations, but the emergence of something called healthcare conversion or legacy foundations, and you'll hear those used as synonyms. Sometimes they have little different heritage and why people might say legacy versus conversion, but for our purposes here, we'll assume they are the same. There are 400 plus of these foundations in the country. There is now one in every state, with the emergence of a foundation in Casper, Wyoming. Wyoming was the lone holdout that did not have a healthcare conversion foundation. We are now either ending the third wave or beginning the fourth wave of the conversion foundation movement, which started in the mid-late 80s. And the majority of healthcare conversions in the early days were nonprofit hospitals that were being sold to for-profit, publicly traded healthcare corporations, often based in Nashville or similar Tennessee locations, still going on. Increasingly, healthcare conversion foundations might be an insurance company that was nonprofit or went to for-profit. There's in this region, northern New England, there's very good examples of healthcare insurance conversions in both Maine and New Hampshire that have ended up with really effective health foundations that came out of those. And then increasingly, as healthcare is changing, county and local government often no longer has the skills, tools to be in the healthcare business, so they are selling off their hospitals, often to nonprofits, but foundations are still being formed. And the last might be, and it's important, certainly in certain places in the United States, certain regions, where the religious orders or the church that was had really formed a hospital system sometime well into the 1800s and continuing now. Aging of Catholic sisters, just different priorities of a Methodist or Episcopal church, and many of those systems have transitioned to either for-profit or to sales to a larger nonprofit system, and foundations were created. So the largest of these healthcare conversion foundations is located in New York State, and was a Medicaid managed care product that the Catholic diocese owned. So that's called the Mother Cabrini Foundation, a little over $4 billion, give you a little sense of scale. There are a number of that size, but a dozen of that size around the country. But there's also healthcare conversion foundations, perhaps in your community and where you live, that might only represent one or two counties, and their endowment might be as small as $10 or $20 million, which means they might be grant making $500,000 every year rather than 75 or 100 or 200 million. So there's healthcare conversions of every size and shape, and I could certainly point people to resources where they can find out more. But it's safe to say that wherever you are in the audience, there is likely to be a health conversion foundation of some kind operating either within your geography or close by. So the types of funders that are interested in rural health, and I keep using this blanket term, private foundation, to represent a number of different kinds of funders that are private, but as you know, bank trusts, and historically people who had bank relationships would leave their money to essentially a bank and their trust office, and the trust office would manage the funds, often over generations. That certainly still takes place. Community foundations, the community foundation movement has boomed over the last 20 or 30 years, even though the first community foundations, the first one being the Cleveland Foundation, 1918, I believe. And family foundations, I'm sure where we sit here in Keene and wherever you are as an audience member, you have multiples of family foundations, some of which are very public and present, have open application, kind of protocols, others that are much more private and little underground, and you may need to know someone to know someone. Refreshing. I was just going through the different types of private foundations and other kind of private dollars that can go to support rural health. So the bank trusts we mentioned, community foundations, ever present in the United States, family foundations, and then healthcare conversions. We've talked about that a little bit. There are certainly individual donors, not just people of very public wealth, but who have interest in rural health, and that's probably worth a whole other conversation on how to identify them, how to tap into that. But certainly there are people who have interests in your community and working on rural health issues you may not be aware of, and it certainly merits some attention to a strategy on how to get engaged with them. And then some communities in rural places still have very active United Ways. Others has kind of passed by a little bit as the United Way kind of corporate fundraising model has kind of moved on as places have offshored and don't have as much local ownership, but still in some places a very important source of funding for rural health. And then the public agencies, which Terrell and Christine are going to touch upon in one way or another, probably. So state agencies, number of federal agencies, 3 commissions, which are all federal employees, but work in quite an independent way, but all have rural health interests. Appalachian Regional Commission, which extends actually from Western New York State down to Northern Alabama. Not traditionally what many of us might think of as Appalachia, West Virginia, Western North Carolina, but the federal definition is much broader than that. Delta Regional Commission is in 8 states, has a number of rural health interests, and that would include states like Illinois, Missouri, not just Mississippi, as we might think of the Delta, and Denali Regional Commission, which has a similar structure but is Alaska only. So I've mentioned a couple times the impact of the social determinants of health, and certainly these slides could be made available to anyone in the audience, because this is the best slide I've seen, which gives kind of this bullet point presentation of the kinds of things that we might think of as impacting an individual's health, and I'd also say the health of a community. This is from the American Hospital Association, so well done and well curated. But all of these things we know have impact on mortality, life expectancy, healthcare expenditures, health status, and functional limitations. So it would have been very unusual for a health funder or anyone interested in rural health to 20 years ago, I would say, talk about food access as a rural health issue. And now we talk about that just as a kind of a matter of course. Similarly, we wouldn't have talked about rural park availability. The mythology of rural places is a lot of open spaces and kids are outside and everyone's recreating. And it's actually often exactly the opposite. There are no formal park systems. There's no shoulder to walk on the side of the road. People live, 10, 20, 50 miles away from these kinds of supports. So the availability of recreational opportunities for people in rural communities is really high on the list of private funder interests right now. I think we all know that people who have more stable employment situations and can pay their bills and have a little left over are much more able to take care of themselves in a way that speaks to sustaining health for them and their families. And of course, still, the availability of quality health care, particularly specialty care, which is a huge crisis now in rural America, and one that's been around for quite a while. But the availability of healthcare in general, but very specifically, dental care, mental health care, and kind of all the kinds of specialty services that now people often have to go to a larger urban area to access. And there's a similar graphic, but that's a nice one for a board presentation or other you might have some other use to that I think hammers it home. And we don't think of violence as a social determinant of health, often associated with rural places. Having lived in rural Louisiana, where this was this huge issue. I mean, there's certainly the history of places and how people solve problems, and kind of the unsettling of culture can often lead to violence, and that is both a public health issue, but is certainly one that impacts health status, social determinants of health. So many of you may have seen a slide that looks more or less like this, but I always like to include it. Life expectancy in the United States depends almost entirely, not depends in terms of causation, but is related certainly to where you live. And unlike another kind of myth, the idea that, well, people living in fresh air, rural places live longer, it's actually often quite the opposite. And I'm doing work now in West Virginia where it is very much the opposite in a state that is almost entirely rural. The largest urban area in West Virginia is little over 40,000 people for the entire state. But you'll see, life expectancy, yes, in rural places in the West and some in the upper Midwest, life expectancy is excellent, but in other rural places in the Deep South and certainly in tribal settings is really quite poor. So it's always important, I think, to recognize that, as we often say, there's certainly no one rural in terms of life expectancy. And funders, and as you think about securing funding, funders who are interested in these kinds of issues really want partnerships with people who are really, really savvy about this issue. That they're not trying to do programming or do advocacy with the sense that there is one rural in terms of rural health. There's many pictures of that, and this map, this is one way to portray it. So we often get asked in the funder community, we're really stumped on how to define rural. And so it's just been problematic for our board, for our staff. We don't know where to start. Clearly, people would say most parts of Alaska are rural, but you wouldn't necessarily say that, huge chunks of California are rural, just in terms of kind of a national perception. So while this is not a granular look at what is rural, because this is from the federal definitions of metro and non-metro, you'll see that the United States is dominantly rural. And one of my messages to both funders and to grant seekers or people involved in rural health project development is to really be aware of the density of kind of rural geography in the United States. It's not an afterthought. It's depending on whose definition you go by. It's 97% of the geography. And this map, I think, is a nice illustration. There are seemingly hundreds of very confusing maps about rural definitions, but I think for a funder perspective and often for people involved in grant seeking around rural health, this is as good a one as any, and I think is just digestible by most. And now I have three maps, which just to emphasize that clearly, as people are grant seeking and funders particularly are not well versed in some of this, that rural America is not white, that you'll see certainly in the Southeast dominant African American communities that are rural, and including in places that you wouldn't necessarily think of, like East Texas. And then this map will look very different when there's one created from the 2020 census. And you'll see much more penetration of Hispanic Latino population in rural around the country. Places like Georgia and South Carolina, it's just changing dynamically and dramatically over the last decade. So this map is not up to date, but you'll see clearly there's density of rural Hispanic Latino communities throughout the Southwest and in Florida and a few other places, Nevada and on from there. And our native communities, about 54% If Native Americans or Alaska Natives live in rural places, by no means they all live in kind of reservations or tribal properties, but this gives you a little sense of population density. So kind of the second set of what I'm going to talk about today is certainly I think we're all aware from just a kind of popular discourse focus on equity related to a lot of events in the last couple of years. And funders have been engaged in issues around equity for, I'd say, the last 20 years, some much more deeply than others. The whole notion of rural equity is one that is relatively new to funders. It's one I would like to say I'm part of the movement to introduce this into the funder considerations or funder strategies, that the complexity of when you're talking about rural health in this broad sense, and funders have to take advantage of what we know about the way rural communities work and what the dimensions of rural equity might look like. So I will briefly go through 4 items, but here's the list: racial equity, equity of opportunity, economic inclusion, distribution of civic power. Multidimensional. I always reflect on work I did 3 or 4 years ago where I ended up interviewing, I think, about 85 funders who had rural interests around the country. And we had a series of 3 or 4 questions around equity. Essentially, you're a funder. Do you have a specific equity initiative, related to your rural work? What are the equity considerations on your board or strategies? Fully a quarter of the respondents, all of whom were living, working in rural areas, their response was, we have no equity issues here. And because their frame was entirely race-based, and I'm certainly in favor of really expanding this whole notion of rural equity beyond that. So we went through the race ethnicity map, so completely a consideration both for grant seekers as well as for funders in terms of really understanding who lives in your community. Some really eye-opening moments have taken place as a result of COVID, where people of color had huge COVID outbreaks related to meatpacking or kind of prison populations. And I think it was quite affecting how little often local government or kind of community leaders knew that there were people of color in their community in these very rural places. And so this was all very surprising to them, and I think has lent itself to some discussions that are going to be productive over time. And talk about economic inclusion. So much of the economic policy of states, the kind of things that are decided on the legislative level, legislative apportionment, how federal funds flow through states, has certainly a very urban focus, and often does not include rural communities in the future of the state, for example. And so the equity issues related to economic inclusion are often quite profound. Equal opportunity and infrastructure, where are roads built, who has access to an airport, who has access to good water, where are state and federal, local investments in these kinds of things. And often you'll find rural communities that don't have both the resources and the infrastructure to look forward. And increasingly, health funders are understanding that the quality of water, for example, in a rural region of the state directly impacts not just people's health, but the ability to recruit employers, the ability to sustain people in community in terms of aging in place, and just the ability to live in kind of the modern era in some ways. And certainly broadband is part of this, but it's also the kind of fundamental things like water and transportation. And lastly, distribution of civic power. So a fault of many funders, and certainly of grant seekers, is to only recognize those in rural communities who have traditionally held power, and that may be through land ownership of economic means of economic opportunity, tradition of multi-generational elected officials. And the problem with that is that often doesn't include newer people in the community, people of color who have never historically been included, or just people who have never had a voice. I always like to say there are counties and parishes in the United States where 3 or 4 families may own the entirety of all the land in the county. And that continues to be true. And if you're an urban funder or a funder that's not really conversant in kind of the reality of rural, the rural economy, you may not know that, but that still exists. And so whatever funders and grant seekers can do to push past this idea that 3 or 4 or 5 families or 10 individuals can make decisions for an entire county or region of the state. So now I'll go through a series of 8 or 10 slides, which were prepared for a different conference, but I think still really hold true. And it's the kinds of issues that health funders are paying attention to, and nonprofits who are trying to work with funders should really be paying attention to, but have really become much more apparent as a result of COVID. So very contemporary, very current. So rural childcare is something that private funders rarely paid any attention to. Not really any reason for that. Kind of a low density family, small business kind of orientation that many funders didn't think had much to do with the health of the community. Well, the very fragile kind of barely hanging on rural childcare systems have hemorrhaged severely during COVID, and often are not able to be rebuilt. So rural health funders or funders interested in rural health are really interested in what might be new ways of looking at building a rural childcare system that obviously impacts health of children, impacts families' ability to work, impacts a whole set of social determinants of health, going back to what we were talking about before. Been some really exciting, promising work pre-COVID, but accelerated during COVID in Vermont, if people want to take a look at that. But many health funders now want to talk about rural childcare. And so if you're interested in that or see that as an issue in your rural community, I think there is a willing audience where there wasn't one before. Similarly, rural rental housing. Who was thinking about the availability of rural rental housing in terms of quality and access from a funder perspective? No one. And now related to COVID, but also a lot of USDA-backed rural rental housing going private market, particularly in places that are desirable, whether it be new infusion of people moving from other states who have some wealth. So there is a crisis in the rural rental housing market that funders and I would hope nonprofits and people in rural communities are starting to acknowledge and can really participate in. And there are federal people who certainly want to have those conversations, but there are private foundation and other kinds of donors who want to have those conversations too. Been very, very little kind of affordable rural rental housing built in the United States in the last 30 years. And that has to change. Social isolation. There's a large group of funders under the umbrella of grant makers and aging, as well as many other funders who are finally recognizing that the ability of rural adults to age in place is not something that is easily done. There's often not any infrastructure for that. And what are kind of new ideas? What's innovation for how older adults can sustain in rural communities? Often, as I think we all know, being forced to move to the more urban or suburban communities with their adult children, or to live, move to assisted living or some other situations that are no longer in their community. How can you sustain older adults in your community? mental health, the face-to-face mental health system such as it existed, which was relatively fragile to begin with in rural America, often fell apart during COVID. Lack of technology and broadband, and particularly I'm aware of some really good research that's been done on impacts on people in recovery from opioids and other kind of narcotics of that sort. And the inability to see people in person has really rendered a whole different type of mental health crisis in rural America. Every funder who has rural interests wants to talk about this, whether they're a health funder or not. It's just so top of mind. So whether you're a nonprofit who is in the rural mental health business, or say nonprofit that's more a generalized health and human service organization, funders want to talk about rural mental health in ways that they weren't in the past. I think we have known this to be an issue for decades now. The demise of local newspapers in rural places, demise of local radio, which used to be an important source of information for people. Much of that is now corporately owned or syndicated programming rather than locally generated. So where can rural people get, as in COVID or as in kind of the reinvention of a rural health system, where can they get good information about what's available in their community? And so there are funders now who are very interested in different types of kind of the reinvention of rural media. So what's the ability of say a college or a local government to be a kind of news and information provider in ways that no one would have ever thought of, that it was a private marketplace, and now there's interest in funders in doing something that's for the benefit of the whole community that isn't happening organically. So funders feel a role in stimulating some of that. Investing in online nonprofit news sites, kind of dedicated social media that has kind of a very much kind of good government overlay to it about news and information. Touched upon equity issues of community engagement and leadership. Who gets to make decisions in rural America in a particular community or a region of a state? It's often been very limited to small groups of people. There's often been race, gender bias in who gets to make those decisions. And funders are really interested in working with nonprofits and communities who want to change that, or want to at least certainly be more inclusive in an intentional way. And that's really been highlighted in COVID in ways that has changed the conversation for the better. COVID, do we really know who lives in the rural regions? Touched upon that with the map. I'm reflecting on a New York Times piece early in COVID, Guyman, Oklahoma, which is in the Panhandle, one of the hottest places in America. It's a tough place to live, perhaps, for just in terms of the weather and kind of the ability, the means of economic opportunity, but enormous outbreaks in a meatpacking plant there, entirely Hispanic Latino workforce, and kind of the reaction of the community was much along the lines of, we don't know any of these people. How did this happen to us? So people living right in their community who really had no day-to-day interaction with the community at large. And I think there was almost immediate recognition that had to change in terms of this response to COVID. This is an issue I don't think anyone was talking about 5 or 10 years ago, but now is top of mind for a lot of funders. Some of that goes along with the closure of rural hospitals, but maternity care often being very limited now in rural places where 20 or 30 years ago it was actually fairly stable and well resourced. And the whole issue of rural maternal mortality, which is something we shouldn't even be talking about because it shouldn't exist, is I think a really profound public health issue that a lot of funders are interested in. And I'm going through all this list of issues just as you, as an audience member, you may not have known, or it may have have been kind of in the back of your mind that this kind of issue might be of interest to funders. And it's like, well, all these issues, and some of these are more specific than others, but all are of interest to rural funders in the sense of the kind of things you can start a conversation with if you're a potential grant seeker. And broadband, the sense for many funders was broadband was the kind of thing that government did. Broadband was the kind of thing that enormous national funders could invest in because the costs were tens of millions of dollars, that we as a family foundation granting $1 million a year for 6 rural counties really had no role to play. I think we now know there's actually critical leadership roles that rural funders and rural grant seekers in partnership can play in essentially positioning communities for broadband. There's been a huge infusion of broadband money from federal sources. Much of it's still coming online. In June, there was an announcement of $1 billion for rural tribal broadband. And those announcements will probably be made towards the end of the year. The grant applications just closed in early September. But that's unprecedented, probably once in a lifetime. So what's the ability, if you're proximate to tribal communities, what's the ability of a nonprofit, a local government to join with a tribe, for example, in creating a rural public utility, tribal owned, but that you can buy into? And there's some good examples. The one we talk about most is from the Nez Perce tribe, which is in northern, I guess I'd call it north central Idaho. And that's exactly what they've created. They've created a public utility that extends well past their tribal members, or you as a rural community member in counties adjacent can purchase broadband from the tribal entity in ways that were absolutely unavailable. These were places with zero broadband access, and now they have really good broadband access through this kind of tribal community partnership. Really relevant in 25 or 27 states in the United States. And so those of you who are in some of those states that have kind of a tribal presence, most tribes will be engaged in this because the federal funding allocation was so large. And so I would certainly encourage you to reach out to some of the tribal governments, because now is exactly the time they're going to be planning perhaps what the implementation or the development might look like. And rural communities can join with tribes to do this, and all over the country. And finally, and this mirrors some of my earlier comments, health funders are no longer only interested in health care, and they're no longer even just interested in some of these social determinants of health, but most funders who think themselves as supporting better health for the community or the health of the community at large, many funders would say they're essentially interested in anything. And that was just not true 5, 10, 20 years ago. And that's not each and every one, certainly. But the more nonprofits, local governments can talk to funders about kind of multiple issues and how they intersect, how K through 12 broadband availability impacts employers, impacts childcare. This is all really critical to the future of these communities, but is really critical to how the kinds of conversations that funders want to have with communities, very different than it's been in the past. So one of the laments of private foundations and donors is that, well, we'd love to do more rural work, but there's no nonprofits to fund. The nonprofit infrastructure is too weak, too limited. That may be true with a very narrow definition of nonprofit, but funders are increasingly recognizing that some of the best grantees are not nonprofits in the way we use that term, but are the kinds of anchor institutions that are present in almost every rural community. So the idea of a library being the leader of a broadband effort, for example, or ag extension being the leadership group over childcare, that's all very new and ways funders are still lagging a little bit, but that now is exactly the time that a rural nonprofit, a rural governmental agency, some kind of rural leadership group should be talking to funders about the ways they can fund rural places. And here's just in terms of leadership and the kinds of groups that exist everywhere, but funders haven't thought about as necessarily connected to health in any way. So libraries, ag extension, locally owned media, county manager, depending on the structure, school districts, community colleges, state offices of rural health, rural development, rural transportation, your federal regional people. Every state, as you may know, has a USDA representative specific to that state. There are statewide community foundations that may not be present physically in these rural places, but are very engaged in terms of having both donors and issue interests. And then wide variety of church groups who can be in leadership roles over health. And there are examples of all these around the country. I wish there were more. Wish it was denser, but we're just kind of on this new journey that, going back to some of my initial comments, that the idea of improving the health of a community or being involved in rural health doesn't mean just with the hospital and some doctors. It's with all these civic institutions. And often, for whatever reason, a denominational church group that might be, the western region of a rural state might have some issue interests that directly square with improving rural health. They may not think about it that way, but it may be exactly in sync. And it's often the language that kind of keeps us apart. So, getting towards the end here, a little instruction. So how do rural serving nonprofits, and you could also translate that to local government, county government, and related institutions we just talked about. If you're new to this, how do you begin your path to funder knowledge and relationships? So there are obviously state rural health associations, there's offices of rural health, but importantly, there are state offices in every state that have very defined and sometimes mandated rural interests that you may not think of as health, but as we just talked about, are square in the health space. So transportation, education, commerce, agriculture could go on and on from there. So you may know those people already, never thought of them as in the health improvement business. They're increasingly redefining or thinking about how their roles intersect with this improving community health. How can a nonprofit or government agencies or some combination of the two bring together groups of interested people, could be individuals, could be church leaders, around an issue and present them to funders? One of the unfortunate defaults of a funder attempting to do rural work is we can't be in every town of 500 or 1,000. We need scale. That would be, you hear that over and over in the funder community. We need scale. And funders in general are not very good at creating scale. They need scale to be presented to them. So the ability of a nonprofit or this kind of aggregation of community leaders, multiple counties, a section of the state, to present themselves to funders with not necessarily an answer, but to engage in conversation over any of the issues we talked about. I've probably mentioned 15 issues since I've been talking. And so any of those issues, but the ability to present to a funder, hey, it's not just 2 towns of 500, it's actually 7 counties. And we have people from 7 counties who want to engage in that conversation. We have mutual interests, and we think we have some interesting ideas for you. Yes, this is an important idea and one that seems so intuitive, but is unfortunately not practiced enough. Often, and this would be true of nonprofits in general, but I've seen it, certainly the work I've done the last 20 years, which has been rural focused, of trying to engage with funders around deficits. We don't have A, B, C, D, and E, F, G, H, I to Z. We don't have all these things. Please help us, write us a check. An incredibly ineffective approach to any foundation or any other type of funder. You're just presenting a slate of issues that seem unsolvable to any funder, and it's just too overwhelming. but also doesn't give you any hope in the funder role that there's actually any group of people or any answers, anything to build on. Like you're starting from such a deficit mindset. Well, why would we expect things to change or improve? Funders and donors want to hear about little glimmers of light that are happening that you might want to build on. That seems that someone's had a good idea and they have built a mini childcare system in one rural county, and you want to advance that. Or, there is a weekend solution someone's developed about mental health access, but it's just been limited to one place 2 hours a week. That there's something in motion. There's some sense that people are moving forward and are not stuck about their kind of the deficit piece. Understanding rural communities in general are incredibly under-resourced for all sorts of reasons, historical and scale and governmental policy. But in terms of the funder community wants to hear about optimistic solutions rather than this kind of deficit mindset. So always important, and I'm always surprised, even people in fairly remote areas, how little they know about what their funder landscape is. So the ability to do some due diligence, and there are ways to do that through state grantmaker associations. There are public resources, Foundation Center, and other things that are online and in libraries, still in hard copy, that give you a better sense of this. But I'm often very surprised at how little people know about the variety of foundations and funding opportunities, not just that are based in their community, but might be statewide they have access to. So much of that kind of research due diligence, as you can do, goes a long way to initiating a conversation with a funder. They think you've kind of done your homework, and it feels you're a little more substance what you might talk about. And just a brief listing of some of the resources, and as I said, we'll make the slides available. And not this is a very small selection of kind of groups where you might find some good information. And Daily Yonder I'll mention, which is a daily news journal, essentially of rural news on every issue we've talked about today. There's probably been a piece in the last 6 months. Christine's Hub she's going to talk about, and on from there. But there are a lot of many more publicly accessible resources for nonprofits, local grant seeking, local people interested in connecting with funders that get you into the kind of behind the scenes of the funder world than there ever were before. There's now a number of independent kind of news sources. Some are free, some unfortunately have a paywall. But the kinds of things that when I was a grant seeker in Catholic healthcare 25 years ago, that I would have had to have a friend of a friend of a friend and, have a secret conversation about, that's all publicly available now in many ways, or at least there's insight into how the systems work. So I would certainly encourage you to dig as deeply as you can, or as you care to connect some of these kind of funder interests, funder structures with the issues that we've just referenced. So thank you all for sticking with it, and hopefully that gave you a good orientation to kind of at least the private foundation community around the country, and how we think about rural health, kind of rural, I always like the term rural community vitality, and what can be done to sustain that. We know there's a lot more best practice that's been identified and is available than ever before. We still haven't approached having a field of rural philanthropy, but I think we're increasingly getting towards at least a set of practices that rural funders can pursue with rural communities that have a chance of better outcomes. So much of the rural work done by foundations through the 70s, 80s, 90s was throwing lots of money into often smaller rural places, often incredibly poor, under-resourced rural places, without understanding cultural context, assets, was all deficit-based. And I think that's almost in the past. We're to this renaissance of how funders might be helpful to rural communities in ways that are this kind of asset-based, holistic, and often involved a pretty long developmental journey of 5 or 10 years, not just dumping millions of dollars with expectations of change over 18 months. And that what comes with that, with some of the recent federal funding, is exactly that challenge. How can rural communities digest in a manageable way all this federal money going through states intended to improve rural health? But I would say ideally that takes place over a much longer time frame. So that's it for me for now. And if there are questions that come through the chat, I'm happy to take them. But I'm going to pass it on to Christine.
Thanks. All right. Thanks, Alan. That was great. So I'm mostly going to be talking about resources that are available at the federal level to help you in your searches for funding opportunities. Alan kind of set the stage with the some of the whys and the how of that, but I will talk mostly about those resources that are available. But before I do that, this slide shows some of the goals that I think communities should really have for health and health care. So ensuring the health and well-being of rural residents. So that includes some of those social determinants as well as healthcare itself. But then access to local high-quality healthcare that residents trust and can afford. So access is really a huge issue in a lot of communities, and especially for people who might have barriers such as poverty, transportation, inability to take time off of work. All of those are things that get in the way of being able to access health care. And then the last one is a strong local economy, because we know that health of the population and access to health care are very much tied to the ability of the local economy to thrive. So we need to consider the economic impact of healthcare in our thoughts about, why should we support local healthcare and how can we support local healthcare? So this slide has some statistics from an economic impact of rural healthcare from the National Center for Rural Health Works, and they found that a typical critical access hospital, so a small hospital under 25 beds, has typically 127 employees and wages and benefits of $6 million. So total, and then they use a multiplier because people who are employed at the local hospital also spend in the community. So there's a multiplier effect that happens as those dollars trickle through the local economy. So that total impact on the community is 170 jobs and $7.1 million in wages and benefits. And that's a lot for a small town. So really a big impact. Similarly, with a rural health clinic, they operate on a little smaller scale than a hospital, but still have 9.7 employees on average and wages and benefits of $0.8 million, with total economic impact of 12.6 jobs and $1 million in wages and benefits. So why would rural healthcare need the support of the community is a question, because oftentimes healthcare is run as a business or a nonprofit business often. But there are some, if we value the access, I think we need to take a look at what are some of the challenges that those organizations running healthcare in rural communities have. Alan talked about scale. Similarly, in a rural hospital, there's a lower volume or smaller scale that they operate at, and that creates economic challenges. It's just much harder to make a profit when you're working at a small scale. And yet it's critically important that those services be there. You have to maintain that capacity, whether you have 3 people coming into your emergency room a month or 2,000. You need those services. Distance is a factor for some services. So if you're operating home health or EMS, they have to travel further distance. That costs in both fuel, vehicle maintenance, and staff time is a really big factor in that as well. And speaking of staff, workforce costs are a big consideration in rural communities. And I think the conventional wisdom was always that you can pay people a lot less in rural areas, and because the cost of living is lower, and so therefore they should be paid less. But the reality is, if you expect to pay a physician less in a rural community, you're going to have a lot of vacancies because they expect to be paid the same, and sometimes need incentives to come to rural communities. So workforce costs are huge. And the other thing is, if you do have vacancies and need to rely on locums to fill in, or traveling nurses, those cost a lot more. So, and in a rural community, you often don't have the ability to just slide someone out of one position into another because you have so many fewer staff. And also in rural communities, often we have patients who have higher needs. So we have higher poverty rates. We have people who are aging, people who have chronic conditions, and people who are uninsured or underinsured, who may be more expensive to serve. In recent years, we've had a changing healthcare landscape. There have been so many changes in healthcare. The ACA, I think, was a big one in terms of kind of being the impetus for a lot of the changes, but also in just kind of how healthcare is delivered, lots of regulatory issues. And so there are just, for these rural hospitals, there have been a lot of things to navigate over the last few years. And reimbursement issues are kind of a perennial issue as well. Some rural facilities are paid on a cost basis, but even there, it's allowable costs and subject to sequestration and in Medicare. And I think reimbursement often doesn't actually cover their costs. So there have been 138 rural hospitals closed since 2010, and thanks to the North Carolina Rural Health Research Program for tracking those closures. They've done a great job in doing that. So 46% of rural hospitals have a negative operating margin. And I think that's a really striking number. And, how do you keep a hospital open if you're operating at a loss year after year? It's really difficult to do. And the North Carolina Rural Health Research Program also found that Medicaid expansion was a factor in some of these hospital closures, because it does affect the profitability of the hospital, whether your state did decide to expand or not, makes a difference there. And we talk a lot about rural hospital closures, and I also want to mention that it's not just hospitals. Sometimes it's services within hospitals, but also other types of providers. Rural health clinics have closed, pharmacies, nursing homes. So I think it's something to really consider as these communities lose access to services. So with a hospital closure, there are definite impacts on the community. It increases the strain on the EMS system, because instead of taking somebody to the local hospital, they maybe have to take people 30, 40 miles away, depending on the area, sometimes more. So in that strain is costs, but also the human factor, because a lot of EMS in rural areas is volunteer. And how do you get people to volunteer when you're asking them to work more and more hours? Also for the patient, increased time and transportation to services, so that maybe, even for basic primary care, going to other communities, more barriers to care. Again, I talked earlier about whether you can take time off of work, whether you have transportation, some of those sorts of things. And so these sorts of closures just exacerbate those barriers to care. So the average direct loss of a hospital closure, 73 jobs and $4.4 million in wages and benefits. So what can we do? And I mentioned that the community plays a role in maintaining healthcare. Obviously the healthcare facilities that you have the lead, but the community support and engagement in some of these processes is really, really important. And the first, I'm going to talk about some actual resources now. So these resources are found on the Rural Health Information Hub website. So the first is the capital funding for rural healthcare topic guide. And this topic guide covers how to find funding for things like building and construction, renovations, expansion, as well as major equipment. And so it covers funding options such as loans and loan guarantees, often from federal sources, such as the USDA or HUD or SBA. So this topic guide lists a lot of those types of resources and how to find more information and how to engage in that process. Also, grants for capital funding are not as readily available as loans and loan guarantees, but there are some funders who offer some limited grants in that capacity. It also gives some tips for fundraising and engaging the community to get funding for those sorts of capital projects. We also have a topic guide on the RHI Hub website on applying for grants. And we know that in rural communities, there isn't always a designated grant writer or somebody who that's their job. In urban facilities, oftentimes they have, a very specialized grant writer. But in rural communities, sometimes it's the physical therapist writing the grant, or or a community member. So if that's something that, if writing is something that you have a special talent in, that's something that you could contribute in your community. So this topic guide talks about how to find grant opportunities and how to write your proposal and find assistance in doing that, how to plan for sustainability, and how to find and use statistics and maps within your application. Also, some tips on working with funders. We also have a toolkit specifically on working with foundations. And I know Alan was a contributor to the information in that toolkit. So gives a lot of really great advice on how to work with foundations and build those relationships so that you can have ongoing relationships and take advantage of those resources. So when you're looking for funding, here are some tips on places to look or things to think about. There's the RHI Hub funding database, which I'll talk about a little more in a minute. There's the foundation directory online. Corporate giving. So are there corporations operating locally that might be interested in giving, and other fundraising? And that can be informed by your local environment. And if you need help finding funding opportunities, we do offer a resource and referral service at RHI Hub. You can email our information specialists and they can do a funding search to help you find funding opportunities that might be a fit for your community and your particular project. So this shows the online library and where you would find the funding and opportunities on the RHI Hub site. And you can see that you can look at just what's new. So if you're checking in every week, or that's a good place to look. If you're looking for a specific topic or a specific sponsor, or for your state, you can go to those particular pages on the site to find those. And there is the ability to narrow within that. So here's how you narrow it. So you can really drill down to what you're looking for. So if you're looking for just projects or funders that fund FQHCs working on mental health in Nebraska, you can narrow down that far. You might not have a lot of options at that point, but if really what you're looking for is the right option. So I think that's helpful. And this is my contact information, and I'll turn it over to Terrell.
Thanks, Christine. I just love listening to Alan talk about the trends for us to be paying attention to, how we can plug in as community leaders, and then the great thoughts that Chris gave us about thinking about what are the needs of rural communities and where we really can show evidence. I'm happy to be the CEO of the National Organization of State Offices of Rural Health, where we focus on advocacy, education, and partnerships to build capacity of state offices of rural health, who I want you to get to know, and their stakeholders. And I hope that we do a lot of work at NOSAR to build capacity around grant writing. We do a grant writing institute, grant writing beyond the basics, those kinds of things, and I'll share that with you. But I hope that you know that Or do you need me to time out? Okay. Go ahead. All right. One of the things that we're really proud about at NOSOR is our efforts around National Rural Health Day. And Alan talked about how important it is to come to funders and foundations with your bright spots and what your assets are. When we started National Rural Health Day about 11 years ago, we had important national associations and federal funders come to us and say to us, we can't participate in this because our message is that rural America's older, sicker, and poorer. And we've really seen that dime turn. I'm very proud of that just personally, to see the state offices of rural health come along with their rural stakeholders and national partners like RHI Hub and others to say, yeah, we want to talk about bright spots, those little twinkles that Alan mentioned. So I share that with you today because those of you who are interested in building vital rural communities have to tell your story. And we have free resources for you to do that. We take one day every year, November 18th this year. There's lots of toolkits for you. We'll tell a story from every state in the nation this year. We'll do webinars. We'll partner with folks to do Twitter feeds, those kinds of things. But all of the resources are free. They're there for you to put your own brand on along with National Rural Health Day and to be part of telling your bright spot story. So I really hope that you'll do that. But what I'm focused on today in terms of this session is really to help you wrap your head around, if you're not already, and even if you are already, I hope that you'll pick up a few ideas and things to ask yourself about, questions to ask yourself, strategies for seeking grant funding, and a little bit on funding sources and how to approach that effort. Alan and Chris gave you great tips on that. So ask yourself, are you a grant writer? And you probably don't think that you are, but maybe your boss thinks that you are, that you have just become passionate. And I love this little meme or GIF or whatever it was that we found on Facebook. You know, a grant writer is many, many things. Probably your friends think you just beg for help. Your mom thinks that you're a saint and that you're after those, you know, that you're just taking care of the poor and the advocate. People that you work with might think you're the person who grows money on trees. Your boss probably thinks, she just diddles around with writing words and it's a really simple little project. You think you're Hemingway. And in the end, when it comes really down to it, what you do in the middle of the night, some nights, is count your words and make sure you haven't exceeded a word limit. So it really is about all of that. But what I'd ask you to do is to think about yourself as a trend watcher. So much that's important about being successful in grant seeking is watching for local trends. And that old, I come from, I was a child of the 60s and 70s where we said things like think global and act local. And that really is true. So you take those trends that you heard Alan talking about today and you apply them locally. And what difference can you make in your rural community to stop those hospital closures, to focus on the needs of rural community? And, sometimes I say to myself, well, what the heck can I do? How am I going to know? I'm not one of those crystal ball futurists. So how can I watch the trends? So certainly watch the trends of funders to see what they're doing. Watch your state offices of rural health. Alan's already said some of this. You have a great New England Rural Health Association if you're from this part of the country. Certainly look to the National Rural Health Association. Watch what's happening on Twitter with Secretary Becerra. What are they sending out on tweets? Look at the Federal Office of Rural Health Policy website and get on their list, and I'll give you more information. That look to see what CMS is doing with reimbursement of providers, how they're experimenting with chart models and those kinds of things. And I guarantee, and check your competition, who's in your community and what are they doing and how can you glom on and work together. there are so many places to watch. So I think like my big thing is learn to, one person said to me, our Michigan Center for Rural Health director said to me when I started my job, Terrell, your job now is to read. And then, another one says your job is to connect. So just like all of you, we live in a world where we have to do everything. So one of the things, if you're running a nonprofit or if you're seeking to build the work of rural communities, I have some kind of like really direct questions about when you're writing a grant application, or maybe you found a grant, or maybe you're just gearing up, and they're kind of stop and go questions for you, kind of some questions to ask yourself. A lot of times I see people in our work and in my work when I provided technical assistance to rural communities get excited about a grant application, or you find something in the, online directory of funds, but, just hold up just for like a second and ask yourself a few questions. Are you even eligible and able to apply? That's two questions in one. Are you eligible? Probably if you're a for-profit, you need a nonprofit partner. If you're able, you got to be able to say who the heck is going to pull this off. So ask yourself that. Read that eligibility criteria. Know what it is. What is the problem that you are trying to solve? And when Alan was talking, he talked about how funders kind of like this, my words, not his, like a community-wide sort of approach. So what is that problem, and how do you describe it? Because that's really the key to a successful connection for funding. What data do you have? That's when we'll talk more about data, but you're going to need some facts and some evidence. Chris used the word statistics that are available to document your need, maybe just at the local level, but often it's required that you document at the local level. How does it compare in the state, and how does it compare in the nation? And that's a challenge. I'll talk about that a little bit. What partners can help you get this done? This is not easy work, but that idea of a consortium and a collaboration, we talked about that in our previous session a little bit, can make you more effective, give you broader reach, give you more expertise and credibility. What do you want to do about it? I've seen so many stories of, I worked in the small town of Winnemucca, Nevada, and we thought we had a homeless population problem because there were a lot of, I don't think this is a politically correct word, but hobos in town. Lots of people getting in and off the trains, being homeless, transient populations, and they were all over downtown. And I happened to be working with the Small Business Development Center, and the Economic Development Authority was trying to beautify downtown. And the biggest obstacle was, these homeless people are everywhere. So folks said, well, we need a shelter. But we got down and we got into looking at the data. And what we found is that folks needed transportation, they needed care, they needed jobs, they wanted, shelter, maybe they just wanted to get out of town. So really getting down there and documenting what is the data of that target population that you're trying to address, and to move forward with meeting your problem. There's 100 ways to skin a cat, and that'll be the case as you're addressing the problems of your rural community. What can you measure, and how can you measure the benefit of what you want to do about it? Funders want to see some impact, some ability to carry it forward to lead to the next step in addition to solving that problem. What will you have after you finish that you don't have now? That's a great question for a group that you're going to bring together, maybe to help you write your grant. What will we have when we're done that we don't have now? That's about impact and looking towards the future of that. How much is it going to cost? Yeah, I know that I want more resources to plow out more National Rural Health Day resources to all of you, but how much does that cost? What am I talking about doing there? So have an idea in your mind about what that budget is going to be. Who's going to do the work if you get that funded proposal? How many times I've worked with rural communities and they get the grant and then they have that look on their face like, oh no, what? It's just like, oh dear, here we go. Could you find that work plan we submitted? What did we say we were going to do? Is there a match requirement? That is something that you want to look on early on. And if there is a match requirement, if it's a challenge grant or something that is related to a bigger project, where will you get that? And you want to understand if the funder is wanting to build fundraising effort in your community that way. So you're going to want to know, do you have to come up with other funds to be eligible for that? Can you sustain the service, if you will, after the grant? It's almost an ethical question in some ways. So for instance, if you can only do oral health screening for 3 years of a grant project and people start to depend on that, is that what you want? What's going to happen after the 3 years? So there's an RHI Hub and Alan have contributed to a lot of resources around sustainability, and if it's revenue generation, if it's partnership, if it's adoption, if it's perhaps a policy priority. There's lots of ways to think about sustainability. What are your chances of being funded? Sometimes you can often look at review criteria, particularly with federal grant applications. You get 20 points for whether or not you wrote a good needs assessment. You get 15 points for your plan for your partnership and your collaboration. So go through and after you have a good sense of some of the answers to the other questions, and ask yourself, can we win? I can tell you that now, what I observe in my course of the world, if you can't score a 95 or better, you're not going to get funded. I would say I've seen applications get scored at 99 and even 100 and not get scored by strong, reputable organizations, but there's a lot of competition. So, and then I'll say also, if you don't try, you won't get the money. So no guts, no glory. So it's not simple. Check out the 990 funds of some of the funders to see if they're really giving to people like you, especially when you get excited and you see that they give money to faith-based organizations. Well, then you go and look at their 990 and see what they gave grants for, and they're given to summer camps in the city of Detroit, that kind of thing. So it's important to give yourself a nice reality check, and then finally ask yourself who will actually write this application. So, and that's probably you if you're listening in now. So give it also a little bit of a reality check. One of the things I want to tell you, I heard years ago, and I might not have the numbers exactly right, but the Association of Fundraising Professionals once did a study to see where the best return on staff investment is in seeking new funds. Let me tell you, it was not grant writing. It was things like major gift campaigns, planned giving, those kinds of things. So think about this. But what I say about that as someone who's worked off of grants for most of my career is that you can weave it together. But if there are other ways to do it, they require different kinds of skill sets, but it can be almost a foundation for your work, because sometimes you can get a track record and continue the funding. So, but make sure that you know that it is a big investment in time. Formulate your case, those things that I talked to you about. Identify what your organization's goals and their commitments are. I worked with a small hospital one time and found what I thought was a fantastic opportunity to work on daycare services and supporting single moms. Back in those days, they called them displaced homemakers. And it's a little bit weird, and we found a grant, but the idea was to lead them towards nursing assistant careers or other careers that could support the hospital, because they had such a hard time with workforce and do a good thing in the community, and they didn't want anything to do with it. So I got excited. I probably wrote half that grant, and so you're always going to be wanting to check in. And then also prepare your organization and your community and the people that you work with to be a great partner, to understand the trends. So you're always, as a trend watcher, you might just be a part-time secretary of a hospital CEO or in a journalism arena, but you have taken on a leadership position if you're taking on grant seeking effort. So, it's a great way to make a difference in your community. So let's talk about strategies, getting started with data, and then researching and connecting. So one of the biggest things that we need to be able to do is to write a good statement of need. I think it's the most important thing. There's lots, I could probably say that about everything, but the need you want to address must be clearly articulated, must relate to your nonprofit's mission and to your purpose. And hello to the funders as well. They want to marry up. It's a little bit like a dating service. It really documents your credibility to address the need in your community if you are able to document that need really well. I love this little cartoon. It says, data, nah, I just trust my gut. It's two dinosaurs talking to each other. So one of them didn't care about data, and that's what happened to the dinosaurs. So there's lots of places to get data for project planning. Certainly do a literature review. That's not as academic and fancy as it sounds. You can get on RHI Hub. You can go to County Health Rankings with Robert Wood Johnson Foundation. You can look to see what funders put out. You can find out what data there is. Use your own data. Guess what? You probably have data of the numbers of customers that you served in your food bank, or the people in your congregation who are not literate, or whatever that is. You have some data, or your partners probably do. And then know that they like data that's numbers and statistics, but they want your story too, and that's called qualitative data. Be able to tell that story in a little short case example. Don't make it up. It's a good time for a good writer to, and there was this, and you think about 5 clients in your head, and then you have quite the story. So don't do that. I said steal other people's stuff, but what I really mean is kind of keep yourself a file of, oh yeah, Alan Smart said this, or somebody else said that, and I'm going to quote that in my next grant application, or in my case to the board about why we need that, and credit them. Certainly your ability to quote and cite what's going on and with the data and all of that, again, speaks to your credibility. So look for model programs. You can look at policy briefs, bibliographies, funded projects, newspaper articles, grantors, blogs, all of those things. And certainly, honestly, RHI Hub, truly, I am on Chris's advisory board, but you can save yourself a lot by starting there. It truly is one stop. That said, data's not so easy for rural grant writers, and sometimes the way that grants are reviewed are by objective reviewers, outside reviewers. Sometimes in the federal government, it's not unusual for there to have an objective review committee. Some of the folks that get on those committees do have expertise in rural health. They live and work in the Beltway. They're faced with the challenge to review your application independently. But what happens in our sinful human nature as humans, when you get an objective review committee and you get a pile of grants to review, you think to yourself, well, this group applied for $100,000 and they can reach 10,000 people with their outreach effort. And in this little tiny hamlet in New England, they are going to be lucky if they can reach 200. And they divide 100,000 by 10,000 and 200, and guess who wins? The more urban place. So we have to be champions for the needs of rural communities with our data. So reviewers are going to want to see data specific to the service area. Let's face it, that's not easy to get. They want to know how many people the project will serve, and if there is a high level of need. So what our job is to find sub-county data, which is not so easy. Sometimes we have to extrapolate, and that doesn't mean that you're making it up. You're estimating that, I'm going to talk about Nye County, Nevada. There's a little town called Tonopah, and the whole county includes Pahrump and Tonopah and Round Mountain and other little places, and the whole county population might be 50,000, but this grant is going to apply only to Tonopah. Well, we know about 10% of the population lives there, and so maybe 10% of that need came there. Maybe you don't even have those numbers. You can use different kinds of data that show that the how people are out migrating. Some of those folks that Christine mentioned, people are out shopping outside of their community for health services. Sometimes you can get that. And then, hello, funders, we need funding to get this data. So if you can find a source that helps you really document the need and where the juice is worth the squeeze for them to invest, perhaps that's an opportunity for you. When you're talking about small populations, thank you, Sharon, for the time warning. Small populations might be high cost. Think about this. If I can only serve 100 people with my application, maybe in a town of 1,000, that's 10% of the population. That might sound better optically than 5% in a bigger community. So make sure you're talking about that, and the reach and the knowledge. Just like there's an impact for job loss and an impact for job gain, there's also an impact for investment in one community members' needs. We have such a huge impact of, just if you look at one family and maybe what they're dealing with substance use disorder, maybe that impacts the other communities. So look at that and the impact that it will make across the board in a community as well. So tell that story as you can. And that's there's a lot of nuance to that. And that's why you start with what you know, and then you're shaping up your case from there. So research and understand the need, and then you start with your concept, and you're planting a seed. So you've got your needs. I really like the idea of a concept paper, because honestly, it kind of helps you get your act together before you start talking to your partners, maybe even your boss or other, and certainly the funder. So you're documenting what the need is, what you want to do about it, what services you'll offer, what rationale did you base that up? Did you just make that up, Terrell? Oh no, I read about a model program on RHI Hub that was funded before, and we can make that work here. Who's going to do it? What will be the structure of how you'll carry out that work? Who's the partnership? What are the benchmarks for when you do that? What are the steps? When are you going to do it? How much will you cost, and how much will it cost, and how will you track it? Honestly, you can write a concept in a page or two. Simple, getting your act together, giving yourself a place to start and to dig in. It'll also help you make a few assignments to help other people help you write if you want to do that together with someone else. So again, you're planting a seed. And then let's just talk pretty quickly about one strategy is, you've done all this work, so you better write it right. Write for reviewers, right? They're all people. I love the Wizard of Oz, one of them wanted a brain, one of them wanted courage, one of them wanted heart, and the other one just wanted to get home. And so you'll see that when you're working with grant reviewers, people think with their mind, their heart, their logical order. So make sure you put a little bit of that in all of the writing to show that you have the capacity to do that need. Consider your target audience. And it's not an easy job to be a reviewer. And by the way, if you ever get a chance, and the Health Resources Services Administration offers and looks for rural reviewers, do that. It's a great way to learn about grant writing more than anybody can tell you in a class. Tell the story, make it jump off the pages to people, lead them to get to know you and what you want. It's okay to use humor. It's okay to show your heart. Stories, but be very, very logical. Make sure you're leading them exactly down that plot of what you want them to know. And you don't have as many words as you might think that you might. So tell your stories. And then I would also say it's really important for you to remember the golden rule of grant writing. That's not the golden rule that you learned in Sunday school. That is the golden rule that they who have the gold, they have rules. And it's different for all of them. There's two things here. There are federal funders. In my world, I'm just going to sort this real basic. Federal funders are typically going to have a whole list of things that you have to do. On the left is kind of a typical Health Resources Services Administration kind of application guide, all their rules. On the right is an example, I think, from the Robert Wood Johnson Foundation, a little bit simpler. They have a portal, you put your stuff in there, and bam, you go. So really understand what the funder is looking for in that written application. And then finally, I'll talk a little bit about research and conducting and connecting with funders. So research private funders, GuideStar has a simple, easy to use guide. You can look up 990s. You probably don't know what you're looking for. Get your fiscal people to help you, or go look in those. There's a schedule and it shows what did they give money for. Maybe you look at their board and you can use that rule to connect your board with their board somehow. Do those kinds of things. So check that out. Look at what their assets are. You heard Alan rattle off, a $20 million foundation, maybe with $20 million is going to give out $500,000 in grants. So take a look and understand how that fits. Once you have a needs-driven concept, and this again is about finding those funds, you're going to write it up, you're going to get your leadership to endorse it, you're going to try to organize your team, share it with partners, and discuss it. So it goes like this, you've got your little concept in front of you because you've done the work. So you say, given this concept and is this a project that fits your mission and your team capacity when you're talking to the partners? Does this match with your view of the world and what you want to advance? Or to the funder, does that match your funding priorities? So you ask that question. And then you do what we learned in the hospital collection office. You stay quiet for a whole minute. And then you wait to see what they say. If you're talking to a federal guy, they're going to say, we really don't know, but I didn't hear you talk about a consortium. If you're talking to a foundation, they might say, I can't talk to you about that. You're lucky you even got through on the phone. Or you'll have a project officer that their interest is piqued and said, well, maybe go read our guidelines again. But you still want to hear what that is, and you'll know if your partner is going to join you. So get bold about being articulate. You're a leader. You say what you know, and you advocate for what you want. Make sure that you're keeping, think about funders in a way that's appropriate to them. It's not, they are different. And Alan talked about that a little bit. It's going to be an easier application process in the most part for private funders. It might be a board decision, so you might want to champion in that room. It's sometimes about cultivating a long-term goal within your organization and with them. And the federal government will be more heavy on the reporting requirements, and they might have performance improvement measures that you have to connect, get introductions. Start with your state office of rural health, use social media and follow people, look at people's website, develop those relationships. And then I'll leave you with this thought. I don't remember, it really is about tenacity. Co-opetition may well turn out to be the transitory path leading to a future where creative collaboration is status quo. So work with your partners. I'm not going to talk a lot about funding sources except for, by golly, the Federal Office of Rural Health Policy. This is their schedule of funding, and you can sign up for their updates. They talk about model programs, resources, all of that. They're a great focal point for rural health, and they need to know you, and you need to know them. There's another one, example of USDA had some emergency rural funding. Alan already talked about USDA. I talked yesterday about connecting with the director. Do that. And then finally, I'd just ask you, is there anything in the chat for us?
I am seeing nothing in the chat. These people are very shy.
Okay, that's fine. My last words to you are, this is a quilt that NOSOR made. All the state offices of rural health contributed to it. Doing the grant writing is kind of like sewing together a quilt. You start with scraps. Sometimes things get crazy. You got to sew in a straight line. It takes tenacity, and then you weave together something beautiful to make a difference in your community.
No, you're perfect. Perfect. So I noticed Alan picked up his microphone. Did you have something else you wanted to say?
I was just going to provide a little emphasis to one of Terrell's slides about kind of the presentation of need. And yeah, what a lot of rural grant seekers don't do a great job at is actually painting the picture of kind of the culture of the place. So yes, you have outside reviewers who may be could be even based in a different rural region in the country. And so what is rural in North Carolina, where in general, the most rural places are 50 miles from a large city, or a city of some size at least, in Montana or Nevada are not. So you need to kind of paint the picture of literally what it looks like when you look out the window.
Mhm.
It's all trees, or is it is it mountains? Is it flat? Because that kind of gets lost in the sauce sometimes. And for people who are reviewing, even large state funders, people need to be able to visualize what you're talking about.
Yeah, I will tell you, I don't know how much digital files weigh, but these digital files are worth their weight in gold or titanium or something. All the things I wish I knew when I started doing development work for healthcare many years ago, they have them all. And one thing I would emphasize is I applied one time to be a HRSA grant reviewer, and they begged for people to do it, and they always need people. And rural people sometimes don't apply. The more rural people we have apply, the bigger voice we get. And don't be afraid. They're really nice to you when you're a grant reviewer. It does take a little time, but it's really interesting. And the best thing about being a grant reviewer is you really learn how to write a grant, because once you've read 10 or 15 on the same subject, you start realizing what people are going to pick up on. So don't hesitate to volunteer if you get the opportunity. So all of these folks have generously agreed to make their slides available on our website at Radically Rural. So thank you so much to all of you. I do need to tell you there's one more exciting event that you can attend. I think it's at 1:30, Juliana, am I right, in the showroom? There is a big expose, how's that for a great word, a tantalizing word, of things people are doing across the country that have been successful. And I think it'll be a lot of fun, and it's kind of our closing event for what we do. And I want to say lastly, thank you to our local Cheshire Medical Center, who is a great supporter of our community, and Don Caruso, its president, for making all of this possible for us. We appreciate the support and appreciate what they do for our community and our area. So I think we're out of time, and thank you very much for coming. We appreciate it. Hope we're back next year, and we'll use some of what we've learned to do even better. Thank you.
Thank you all.